Awesome. Well, I'll just give you a little bit of context on myself, and that way you kind of know who you're talking with. As you mentioned, I'm a ER physician in Houston, Texas. I, have just interest in a whole bunch of stuff, which is sometimes good and sometimes bad. I, kind of stumbled into blockchain, the blockchain world a couple years ago when NFTs were all the craze and every celebrity had, an NFT coming up. And like most people, I was like, this is a fad, a scam, or whatnot. And eventually, I think I was watching like Yahoo Finance or something when someone actually talked about blockchain and the actual utility of tokens and whatnot, and them going beyond getting a cool looking monkey or whatever the case may be. And that's when it kind of clicked that, hey, this is essentially the internet for our kind of future, and it's going to have implications in every sector, and that includes healthcare. And as you know, obviously healthcare has lots and lots of issues and a lot that needs to be fixed and whatnot. And as an ER physician, I see that on a day-to-day basis. And I started doing some digging into, what folks were doing when it comes to healthcare and blockchain and actual technologies that were utility rather than, hype or fad and whatnot. And that's how this, podcast kind of came to be. And that's how I ended up in Austin, and I got to hear your talk. And I was really intrigued and interested by, what you had to say and kind of how I came to reach out. So thanks once again for, responding to my request to chat with me. I guess, obviously I want to talk about Acoer, which you are the CEO of, and, kind of your experiences and things that you've noted kind of in the later part of 2022 and where we're at right now. But I was kind of looking at your profile and I saw that you worked at the CDC and in developing some technologies there and whatnot. I'd love to kind of hear more about your work there, and if we could start there, if that's okay with you.
Yeah, certainly. I think in many ways, my time at the CDC really was formative, highly formative in two areas. One was, more or less as you kind of alluded, your understanding or deep understanding of what's going on in healthcare, and how so many things are broken, and really just how profligate, how wasteful in every context, not just economically, the industry is. I think my eyes really were open during my time at the CDC. I think just being there on the inside, of course, in that role, with the federal context, dealing with states and localities, and really across the board, I just understood so much more than I probably was aware of or really deeply interested in before. That was the first thing. Second thing was really this kind of thinking that there was an opportunity, particularly with some of the new innovative technologies. Yeah, certainly there was a lot of talk about AI, but to me the big aha was that there is a data issue. There's a siloed data issue, and AI, machine learning, all these other things. Ultimately, their efficacy, is dependent on the training data set, and whether or not it's available, whether or not is kind of the data is basically near real time or it's not old data. Let's put it that way. The data can be relied upon on kind of making predictions, and really whether or not ultimately data could be trusted. Could you really know where the data was coming from, and whether or not there was something else that was perhaps more relevant. And a lot of that really kind of ultimately brought it back to this concept of, well, how do we in a kind of a decentralized world, right? Because certainly the CDC, as you know well, is by no means the owner of this data, right? The data is coming from states really own it, but they're coming from all kinds of different sources. How do we know? I mean, first of all, where is the data? Where is it coming from? And how can we systematically and really computationally determine these things? Because if we can't, you're back in the world that actually we're in right now, which is that everything is inefficient. Everything is really, there's a lot of kind of redundant work. Twice, 3 times, 4 times, 5 times or more, we're touching the same data. Sometimes, many times actually, that data is on different forms that nobody can really agree to, or even on fax paper and things like this. So fundamentally, it really kind of opened my eyes on how do we address the heart of the problem, which is, we know the data is siloed. There's no way the data is going to be in one gigantic data lake, as example. That's a silly concept. But knowing that the data is siloed, how do we still find a way to create the pathways that can be trusted, and the interoperability for the software and the data to really kind of be able to access each other and do it in a way that's efficient. So that was the epiphany. That was really kind of what I would say really learned during my time. And since then, I've been really motivated by, I think, the opportunity. I think that there's an opportunity, big opportunity for us, people like myself, yourself, other kind of both, energetic people, but also informed people in this space, who are willing to kind of go beyond the surface level of the initial tension, the initial, I guess, resistance, because there's a lot of that, inertia, if you like, whatever word of choice, and see that there really is plenty we could do, because honestly, the barriers of entry for innovation are pretty low. There's like I mentioned, the industry is I mean, it's astounding that it keeps running the way it is, because so much money goes into it, and it's so poorly run, so inefficient. In most industries are competitive, like financial services. You would, I mean, like, it just would never work. Yet somehow, we use this crutch in the US that, well, it's health data, or well, it's regulated. Well, I mean, construction is regulated, education is regulated. There's so many other industries that are regulated. So in a scenic way, then, really the learning was kind of a deep, much deeper understanding of the problems, but also really kind of a much bigger insight on where some innovations can help. And that's been the focus since then, and trying to really kind of, in some cases, like yourself, I'd imagine, swimming upstream to try and make some changes, because this is not the easiest topic, for people to absorb or put their mind around. Certainly in the world of crypto, as example, people gravitate towards things like cryptocurrencies or DeFi, things like this. Is more intuitive, and there's like 1,000 derivations of it. Whereas with healthcare, they always know that there is a real life element. This is not, you're not just making it up as you go, right? You're not making up your cryptocurrency as you go. There's a whole massive analog, world that you have to interact with, but which includes people like yourself, right? Real healthcare practitioners and physicians, and people who have massive burden of administration and dealing with insurance and all these other things that are real life, that we can't just like magically kind of like just reinvent by basically saying we're going to ignore all those things, right? That we can't just create like a decentralized exchange and just remove all physicians and insurance companies out of the mix, things like that.
Yeah, absolutely. It's you alluded to, it's crazy. Every year we get like a world ranking of stats on maternal mortality or this or that, and we're always definitely not near the top, in the middle in some cases, and at the bottom in others, and we just keep humming along like everything's okay. So it's frustrating, but I'm glad that we're having these conversations and whatnot. So it seems like at the CDC, obviously, you gained a really deep understanding of these inefficiencies and these issues that we are dealing with, and then you obviously in your current role as CEO of Acoer, deal with blockchain, creating tools that fix inefficiencies and issues and whatnot. How did you make that transition into, I guess, a role that is full-time in the blockchain world, and realizing that this may be the thing that is able to seal some of these leaks and take us forward, rather than other solutions out there?
Yeah, again, I was fortunate at the CDC. I had a very good boss, and I was really brought in with the, I guess, the remit to help modernize a lot of the scientific applications, and to the credit of all the folks that brought me on, and the folks that continue to support me, they allowed me to kind of, with a very small team, really handpicked team, to kind of, I guess, at an architectural level, trying to address certain things, right? And as opposed to just one application at a time, because that really would have been a drop in the ocean. Where we had to fundamentally think about how do you build interoperable systems, how do you desilo data. But one of the things that kind of started right there at the CDC, it was this idea that blockchain technology, and honestly, I still to this day firmly believe it, that in public health, and I think COVID was a very, very good example of this. But almost anything with the context of public, or with the specific prefix of public, this idea that you need to kind of bring data that you can, because remember, blockchain doesn't, there's no data on blockchain. It's really a form of it's a ledger of showing transaction flow, right? And certainly I would advocate putting health data on it, or public health data and things like this. But bottom line though was we know, again, COVID is a very good example, that public health events, they really occur across different all kinds of boundaries, time zones, physical boundaries, geopolitical boundaries across the world, and they impact really everybody. And in a kind of a context, it's really, really important that you make the data accessible as quickly as possible. You prove that the data is legitimate, it's coming from legitimate sources, and then you allow the good people at the CDC or other places, the epidemiologists or data analysts to actually do their work. Because again, as you probably already noticed, many times these folks are spending months, well, weeks, if not months, on just doing basic cleaning of data and scrubbing of data and aggregation of data, things that are really of very low value add in the context of being an epidemiologist, right? They're the kind of things that you would expect circa 2022 or 2017 or whatever, that are just done. And in fact, in most industries, they're done. And you're not going to have expensive, kind of highly coveted specialists spend like 80%, 70% of their time just basically doing data jockeying on Excel, which is it's a real scenario. So all to say, that kind of thinking that really blockchain can help, and this silo problem that I described. Then the next couple of years after I left the CDC was, fortunately, unfortunately, I was in the world of CROs and pharmaceuticals and dealing with the other side of it, and dealing with things like how does stuff get to the FDA and how do they approve, and this whole EROM's law of the epiphany that there's this thing called the EROM's law and the inverse, kind of disproportionate, kind of lack of effectiveness of drug development over the last 50, 60 years versus Moore's law, right? And because I was intuitively aware of Moore's law being a technologist. So that kind of, those experiences really led me to think, all right, fundamentally in healthcare, we know that there are application software and things that are built really to meet very, very limited audiences. Sometimes it's just like healthcare administrators, or it's only not for like the ease of use for a physician, as example, like yourself, or for interaction with patients or patient engagement or patient incentivization, or frankly, anything that you would expect to see on a smartphone these days, which is really where all of us are, right? And that's all of us exist, I think it's fair to say. And not just here in the US. In fact, you could argue that in places like Africa, it's even higher, it's a much higher kind of degree of connectedness to smartphones, right? And so it's a global thing. So in that kind of a context, people expect certain experiences, dealing with applications, and none of that really is, or very little of that is the case in today's healthcare in the US. So, and that was my point about the barriers to entry to innovation really being relatively low, right? Versus as example, if I wanted to build another, let's say social media, like an alternative to Instagram, right? Well, okay, going back to EROM's law, the better than the Beatles scenario, right? So it's like, okay, well, that barrier to entry is very, very high. So how do you really differentiate? So bottom line, that then really what was just this idea that we can build better, more usable technologies and software that meets actual users' needs, physicians or patients, right? We can make that experience seem much more mainstream to what they are now, and less burdensome. And also along the way, we can essentially, I'm going to say instill, but it's really like bed in technologies behind the scenes like blockchain that help you believe, using cryptography, allow you to kind of know more about the authenticity of the data, the source of the data, and whether or not you could actually trust whatever it is that you're getting. So that was it. That's kind of, and that's really what we've done over the course of the last few years with Acoer, is build what we think is largely usable technologies that kind of meet the purpose in a modern way, cheaper, faster, real time, but really kind of more or less behind the scenes, build in blockchain type technologies or integrate blockchain type technologies to prove that we're not manipulating data, that whatever data we're showing is actually the source data from wherever we got it, and just simple things like to prove that a transaction actually did occur, that you and I did speak at 5:15 p.m. Eastern time on the 8th of November and prove that. Now, what did we speak about? Well, that's the data that's sitting on a private database, and we're not going to expose that, right? We're not going to expose some patient's healthcare information or observations about a particular treatment, and that would obviously violate HIPAA, but it makes no sense to do that. So that's the thinking, and that's what we've been doing, and we're again, I think in many ways we're still really at the beginning of this, because the rhetoric, and I think you talked about this a few years ago with NFTs, and before that with ICOs, the rhetoric about blockchain and healthcare has been around for a number of years now, but the evidence of it and people actually like putting their money where the mouth is, people like us and swimming upstream like yourself, very little evidence of that, right? And very little kind of real kind of production quality, high scale applications built, and honestly, and some of this is really just a factor of learning things and understanding certain technologies don't actually meet the purpose. Like good people building technologies on underlying platforms, such as maybe it's Ethereum, which really just it doesn't pass certain criteria such as economic viability. It's fine for proof of concept, right? Yeah, it works. You can data send, you can do some token economics, but in reality, you can't scale it because it's just too expensive. It's too slow. It's the getting to finality of transactions takes too much time. So it kind of becomes like shelfware. Yes, you proved a general concept, but in reality, it didn't move the needle.
Yeah, without a doubt. And I definitely want to go over some of the use cases you guys have on your website. And that's one of the things I really liked when I went to the AFR website. You guys give tangible examples of, academic institutions, governments that you've worked with, a lot of, organizations. You go to their site or you go to their kind of platforms, and it's just like these vague, broad statements that are feel good, but there's very little tangible. And so I definitely want to go into those. But one thing you alluded to was, you obviously don't want to put patient health data on the blockchain. And, with blockchain, obviously one of the amazing things about it is it's public in that you can confirm transactions or facts, like we had this conversation, but at the same time, it's very secure. And so I guess my question is, when you are going into conversations with like an academic institution or a state or local government, is there a lot of, to those who are naive when it comes to blockchain and kind of where things are going, is there like a lot of initial pushback? Or when you kind of explain what's public, what's not, having a key to access certain information, do folks kind of, come around to it pretty quickly? What are those conversations like, I guess?
I mean, I don't think there is a singular pattern, right? What I would say though is, when we talk to almost all of our clients, it's certainly in the context of healthcare, our focus is on the functionality that we're either they want or we have, such as our HashLock product, where we do data visualization and aggregation, and you've seen it perhaps for instance, where we visualize clinicaltrials.gov, right, and make it easier. So what we're really trying to emphasize is our ability to manage large-scale data, our ability to understand, for instance, public health data, HL7, and utilities transform it to machine readable and make it more kind of just more purposeful and make it easier to get things done. And then what we do is really we almost, I'm going to say, it'll sound a little bit flippant, but forgive me. I'm going to say we basically throw in the blockchain element. We basically say, look, and you may have seen some examples of this you know, on our site and other places. You know, we also have, you know, just as part of what we do, because of this belief that we really need to kind of show authenticity of data as example in transactions. We also have this button, you know, that's like a green button that says verify. So whenever you see it, what that really means is we have data stamped any transaction, any data, like if you see a date on it, you know, it says last updated on, you know, November 8th at this time, we have actually in real time when that transaction occurred, we basically put an encrypted reference of it on a public blockchain, on Hedera, you know, in our case, right? Now, what does that mean to them? I mean, largely, I think once they kind of understand how we've done it, we'll prove that this is how it works. It's not magic, and there's a public ledger, and if you wanted to look at every like detail of the transaction is out there. What they really kind of gravitate towards is once they see that green verified button, they feel like, okay, I can really trust and rely on this information. So their experience is one where it's an implicit higher degree of confidence about whatever else they're getting, you know, like the visualizations or if we're doing some machine learning on the data, things like this. So that's our general, and the word that I use is abstraction, that we abstract blockchain. So we don't really try and overtly kind of, you know, like make it a thing, you know, and kind of talk about, and certainly we don't get into things like, well, this is our, how we deal with wallets and how we deal with, you know, with key custodianship or you know, token economics or anything like this, unless that's what the client actually wants and they're sophisticated enough to want it. So I'd like the most basic level, it's really like an abstraction layer that we have baked in. We always prove it, but we try not to harp on blockchain as being like this thing. It's more like, here's the solution you want, and blockchain really is an additional bonus, just from our perspective, because we really believe that no matter, you know, kind of what kind of things you're doing with our application, we want to prove that we're not manipulating the data, that there's we don't have some kind of a ciphering or whatever data that we have access to from whatever source, we can prove is flowed thereafter. You know, and of course, this is a very, very important thing to understand, I'm sure you do, is that, you know, proving authenticity of data flow is different than proving that the data is accurate, right? So if you know, as an example, on my health record, you know, my healthcare provider, if somebody goes in, and I've gone there for physical today, you know, and they, you know, transposed, you know, on a blood pressure, as an example, they put in the wrong number, right? Well, on the blockchain, we can prove forever that that information was recorded, but we can't prove if that information is accurate, right? But therein though there's still a significant advantage, because if you see anomalies, you know, again through machine learning or whatever, you can go back and say, well, was this real information? Did this really happen, or is this fake information? Is this somehow manipulated by some, you know, interested parties or whatever? So, but bottom line, though, this is the kind of conversation we have, is helping people understand that, look, you know, in fact, you know this, I'm sure, you know, with HIPAA and with Cures Act and such, many times we don't, what we have access to in terms of like patient data, as an example, is really in memory. You know, we have read access from the original source, like an Epic, you know, EMR, EHR, you know, through a patient's consent. But we certainly don't like copy the data, or we don't displace it, or we don't write on it. There's a whole lot of other, you know, kind of systems and things that, and a process, compliance process for it. So, you know, in our kind of world, we're really just trying to kind of assure our clients that, look, we're not trying to say that through this blockchain or technologies that we're working with, that we're going to create some gigantic proprietary database. You know, we don't want to create another silo. We don't want to create our own index. Like, we don't want to become like the next I'm not going to mention names, but there are plenty of aggregators who buy data or and then they create their own index. So now you become beholden to them, right? They kind of become, you're coupled to them. That is the absolute last thing we want to do. We want to say the data exists in whatever systems. We're providing you a kind of a more trustworthy view of it. And then if you give us consent, we synchronize it on your app of choice or on our app or whatever. But we definitely don't want to create another fiefdom and another index of data. And that's why we, going back to the whole public ledger, that's why we really believe in using a public ledger. And as an example, if we're using an NFT, non-fungible token, to reference consent of a patron, we want that NFT to be on a public ledger. So, Acoer disappears overnight or, whatever. I mean, anything could happen. They could still go to that public ledger using their APIs or the SDK and retrieve and look at that information. And you're not tied to us as a vendor, right? You're not tied to us we're not coupling ourselves to some proprietariness that then later on you're like, well, now that just created more silos. So that's the thinking that we have. Is really abstracted, a focus on the real functions, and as much as we can assure our clients that the data itself is wherever it needs to be. We're just going to allow people with consent to get to it because, certainly with Cures Act, they have the right. They have the right to get to their data, and that's really it.
And that makes complete sense. I have no idea how Wi-Fi works or how credit cards work, but I use them because it works, and I have a certain degree of trust in those systems. And so what you're saying makes complete sense. It's not because of the blockchain that they might want to use your service or your tools or your apps, but it's because it works and it provides fidelity that they're going to want to use it. So I like how you put it. Blockchain is kind of sprinkled on there, and obviously it's verified and everything, but it's not the thing that you harp on over and over again. Kind of, looking at some of the tools that y'all have created and have done work around, a few of them stuck out to me. So I'm just going to mention them. And if you could tell me, one of them or all of them, how the blockchain component of it may have made this, more efficient, better, or if it changed it at all. And, the number one thing that stood out to me was you did some work around opioid related mortality with the state, I believe. And obviously that's a huge issue. And a lot of times we forget about it, but, on a day-to-day basis, especially in the ER, obviously it wreaks havoc on so many lives. And so that was something that stood out. Obviously, I saw y'all did some work around diagnostics and triage when it came to COVID-19. And then clinical research as well. And so, maybe pick one of them or two of them or all of them. And if you could kind of go into how the blockchain component of it may have changed, how this may have been done, say, 10 years ago, 5 years ago, kind of thing.
Yeah, no doubt. So the one that's honestly closest to my heart is the first one that you mentioned, is tracking mortality due to substance abuse, opioid abuse. It is a huge issue. I mean, just better than I do, of course. You deal with it in real life, and I just talk about it from a technology perspective. But it's something that certainly when I was at the CDC, I came across, and of course, before COVID, it was a massive, it was probably I don't want to overstate, but, in the view that I had, it was the biggest public health issue that the US had, was dealing with. And I think, in the 20 years since the turn of the century, that there were over 1 million people had died from opioid and substance abuse. And I don't know what the numbers are right now, but of course, COVID took, certainly took the attention of everyone over the last couple of years, but that problem has not disappeared. And unfortunately, it still is highly pervasive. So bottom line, working with a real, with real practitioners. So the Office of the Medical Examiner, State of Alabama, Jefferson County, the forensic pathologists, people who are literally working, on this, working basically, kind of doing autopsies on people who have died, and they care about this, and then allowing them to very easily look at data, visualize that data, and for them to just kind of see and discover things really kind of at times spontaneously. For instance, looking at kind of heart and brain size of people who have died due to fentanyl substance abuse, and comparing that to published literature, and realizing that it's markedly bigger, right, in both cases. And just through our technology, just through the fact that we can visualize and make it very, very easy for them to dice and splice that information without needing any kind of programmer or any kind of like database specialist. That was huge. And so in that kind of a context, really we basically just embedded DLT or blockchain, and Hedera Hashgraph is the technology that we use. But really all it does, it kind of provides them that green verified check mark. So it's very, very subtle, right? There's no overt, kind of appearance of blockchain, which is really what we love. And this is really kind of fundamentally, and I think we can talk about this all day at different conversation, but fundamentally how you implement DLT is critical in the experience that you want to impute to your software, to your applications. So the way we want to impute the experience is one of a real-time application where the focus is on whatever the functional thing is that you're doing. So for instance, in real time, being able to like look at various data from different sources, including, for instance, autopsy and death case information, which, by the way, the system that we built for state of Alabama is literally the only system, I think, in all the US where autopsy information, and case information and enmeshing of, or rather transposing of law enforcement information, is all in one place. It's all like contiguous. It looks like it's one database, but in reality, we can prove this to you, it's like 7 or 8 different data sources, all kind of in one place. But the real point, though, is all of that is working in real time. And you click on it, it refreshes, it's very, very quick, very responsive. Yet behind the scenes, we're kind of like every time there's a change to the data, every time there's a transaction, like an auditable transaction, we are recording an encrypted reference to it on a public ledger. So we love that. We love the fact that it's all kind of working, and yet we're able to show the auditability, the transparency, and the compliance when and where needed on demand. But it's just happening behind the scenes. All like literally tens of thousands of transactions are being anchored, on a public ledger. But really nobody knows about it, and nobody needs to know about it until such time as they care to know about it. So that's the one I am most, I like personally kind of vested in, and I think it actually really moves the needle because I've seen, unfortunately, we have all seen the alternative of how it's done. How like this is now where unfortunately innovation has not really, kind of appeared in this world of kind of death, mortality tracking or aggregation of for instance, really almost any kind of substance abuse and like factual data such as, when you die and autopsy and things like this. So very close to my heart, and of course goes back to a lot of our CDC, kind of ideas and things that we had come across in at the CDC context. So that's one. The clinical research one, the third one that you mentioned is I think a huge opportunity for really two, I would say, very kind of mundane reasons. Mundane reason number one, there's a huge amount of money in it, right? Massive, this, right? Like, and a huge amount of money across the board. But everybody for public good, even for the reputation of the drug makers, and certainly for the patients, it's better for all of us to be more efficient at this. So patient recruitment, is a huge, it's really a very, very expensive and lengthy and unnecessarily, kind of, difficult process, right? And it could be done, it could be more democratized, it could be a lot less intermediaries, it could be done more in a more modern way with, with applications, with, kind of with ethical applications that do not like, kind of, or at least provide more inclusion and provide more access to the underserved. It's not a panacea. So I think there's a lot of reasons, but certainly since, especially in the US, we're so the commercial angle is so important. I think that's an easy one, right? The reason number one is it's easy to do this, and improve the process. Even a little bit of improvement, in the fitness of the model yields significant results in terms of dollars saved, right? And frankly, perhaps years saved on building or rather kind of pushing your compound through different phases of drug development. And frankly, in some cases, stopping you from doing so because you realize, oh, you're not getting the results that you want early, it's not reproducible, or there's somebody like literally a stone's throw from you doing exactly the same thing and they're further ahead of you. So I think that's reason number one. Reason number two, I think, is the fact that I believe by kind of doing this putting blockchain, we can fundamentally democratize the process. We can fundamentally democratize clinical research. We can provide more incentives for patients to directly, interact with CROs or with sponsors even, to be closer to this whole like rhetoric around patient engagement, and patient orientation. We can actually put some like meat to it and not just like, CEOs, jibber jabbering, but with no results. But I think ultimately this is when we think larger in the larger context of innovation, right? And we saw this for COVID, but COVID was kind of like, we're going to throw everything behind this. It's a global problem in a massive amount of resources. That's not a sustainable model for every, like, for instance, if you're doing a rare liver cancer drug development study, you're not like the US government is not going to put $100 billion behind that, right? So you have to have some way of innovating around this and to become competitive. And I think that's really DLT can significantly help do it, because you can connect and access patients more directly. You can incentivize them to engage better. You can incentivize them to, you can track consent much more accurately and ethically. You can build a community around this. You can connect to researchers. You can create marketplaces, aggregate anonymized marketplaces. All of that can be done much more ethically, much more readily, and more modern way, using a blockchain as an underpinning. So I think those fundamental two reasons, that lowering of the cost right now, but also fundamentally democratizing the process. I'm a firm believer that can happen. It's slow, but we're seeing, for instance, with VitaDAO, where Pfizer's involved, we're seeing that even big companies who you could consider them as being part of the problem are at least intimating that they want to go down this direction. It's slow, but so both of those, I think the going back to kind of the last example you mentioned, I'm not going to get to all the details, but building telehealth applications like the COVID work we did with Mayo. Again, anything telehealth, anytime you're going through an app and there's not like, I'm not really talking to you as a physician, and particularly when you have machine learning involved, which we did, and algorithms, you need to have some way of proving authenticity, that your AI really did look at consented data. It really was this within context, not you didn't take 50 million records from Ascension Health and do whatever you wanted to do, right? So I think those examples and many are part of why you would want to do it. And again, to us, that's part of the new generation of hopefully more ethical and more accountable innovators in this space. Where they're kind of at least partially proving whatever it is they're saying that they're doing.
I really appreciate you going into the details on all of those, and kind of like you alluded to, the opioid mortality is kind of near and dear to my heart as well. Seeing that on a daily basis and seeing that, obviously a lot of resources are being put into it, but those of us that deal with it on a daily basis, you want it to be the #1 headline every day, but it's like once every 6 months a report comes out, and then people kind of put in the rearview mirror kind of thing. So it's nice to see that tools are being used to create break down silos and create verifiable patterns, and then that verification is important when you go to your legislators, when you talk to folks at different organizations, telling them that, hey, these are facts, and they're facts because we can prove it, and getting resources and change off of that. But Thanks so much for, sharing everything that you do. I honestly did learn a whole bunch. All of these conversations are always so much fun, and it re-energizes me, and I'm excited to see, what you keep doing and what Acor keeps doing, and continue this conversation moving forward.
Yeah, thank you. I appreciate opportunity. Yeah, I really love people like yourself, practitioners, you know, um, who care about innovation, like this, and obviously you're using your influence, your knowledge to kind of, help drive at least some education around this. So yeah, great job. Thank you for the opportunity.
Yes, it gets, you see a lot of the broken parts on a day-to-day basis, and it's easy to, get burned out. So this type of stuff, gives me that energy to see that, hey, something's being done. There's possibility and hope and whatnot. So thanks again. And I hope we run into each other at a conference or something soon.
Sounds great. Take care.
Bye.
Thank you.